All right. Good morning, everyone. Thank you for bearing with us as we got everything organized. We've got a few technical difficulties we're still working out. I hear echo, so I'll work on that in just a second. But thank you for being here. I want to introduce Dr. Coskun. She's a board-certified attending physician within the neurology services here at University of Kentucky. She did a residency at UK, followed by a fellowship under Dr. Jaika in memory disorders before joining the faculty at the College of Medicine. Dr. Coskun now leads our K&I memory clinic, Lequembi clinic, and will share with you her expertise this morning. We are so glad to have her. So please welcome Dr. Coskun.
Thank you very much, Sarah. So today we are going to talk about what is anti-amyloid therapy. And then I'm going to tell you about the background on what it is and how we treat this disease. So after me, actually, our own nurse practitioner, Ms. Kim Lowry, is going to present afterwards. So just bear with me. So I will go through this one with you first. So our outline is. Let's see if this is going. Okay. Our outline is I'm going to describe what dementia and MCI is. Then we're going to jump into what Alzheimer's disease. How do we diagnose the disease? How do we treat it? And then our main topic, who gets Lequembi and what is its benefit and the side effect profile. So what is dementia? Dementia is an umbrella term that we use to describe of the symptoms associated with cognitive impairment. So the next, the word that we need to know is what is cognition. Cognition is made of like brain abilities like memory, thinking, language, problem solving, and decision making. So if there is any cognitive problems on in any domain, actually that would eventually cause dementia. So the dementia, actually, as I was telling you, is an umbrella term that could make up many different diseases. So frontotemporal dementia, vascular dementia, Alzheimer's disease dementia, Lewy body dementia, and others can cause dementia. The most common cause for the dementia, though, is Alzheimer's disease. As you know, the person doesn't really come from one day normal to the dementia, the symptoms. So there's a term in between, actually, we call it MCI. MCI is mild cognitive impairment. So someone starts from the normal cognition, normal aging, so all the domains are intact. They can proceed with the MCI. At this stage, actually, some people remains as MCI stable for many years. Some people progress to Alzheimer's disease or dementia, and today we're going to talk about Alzheimer's disease related dementias. And then some people actually goes back to the normal aging. So this is a continuous process, and in fact, it's a very fluid the definition. So what defines the MCI? So the functional loss of functional independence actually defines our disease, MCI or the Alzheimer's disease. As you can see, we have some the tests that we can check the memory, and then there are some the stages that I put it on down here, and then there is the stages that we call, but you don't really have to pay attention on this. What I want you to pay attention, so our abilities, our functional abilities that starts as like going to shopping, watching TV, to keeping appointments, more complicated the functions as travel outside the home, and then more basic towards the more basic as doing daily living required functionals like grooming, riding, or cleaning, bathing, and walking and eat. So this is a continuous functional independency getting lost with time actually defines the Alzheimer's disease. Someone can start from here as MCI, mild cognitive impairment. With the functional loss, it can progress to the severe Alzheimer's disease. So basically, the dementia is defined or we diagnose based on loss of function. So during this period, actually, so before the severe dementia, there is a bunch of other clinical definitions that you don't really have to pay attention. But so we know that before the diagnosis of MCI, someone can experience some signs And then, so that could be like, the episodic memory, short-term memory problems, or some executive functions impairment or visual spatial functions before the MCI starts. So this is progressive and usually starts with one domain of the cognition, as I mentioned earlier, many domains of the cognition that can be impaired with time. So when it's progressed to severe dementia, many more domains actually involved. And then while the cognitive impairment happens, so it affects the function, and then with the time it gets much more progressive. In the meantime, we observe behavioral symptoms which doesn't really correlate with what stage that is. So it can happen anytime and it can fluctuate during the time. But as you can see, the severity can increases, but at one point this can actually gets better towards the end of it. So as I was telling you, the person doesn't really become Alzheimer's disease in overnight. So there are many things happening while this process is going on. So initially, what we know that amyloid plaques actually starts building up and building up. The next is the other processes that happens when they build up. It becomes all these functions actually loads up to become the impaired MCI stage, and then this will progress to Alzheimer's disease. In fact, we know that Alzheimer's disease actually before the MCI diagnosis is given, we have 10 to 20 years before actually some buildup is happening. So what happens in microscopically? So this is a normal process, normal brain, and then when you look at the coronal section, so if you look at from where the eyes, imagine the eyes are over here, so we're looking at the brain. So you see right over here, this is the memory storage area. It's called hippocampus. So, and then this brain actually composed of many the neurons over here. When you look at the sickly Alzheimer's disease brain, you see how shrinkage happens, that brain becomes much smaller, and then you see the holes in the brain actually got bigger, and now look at this, hippocampus is become actually very shrunk, so the memory is being affected. So what happens in the nerve, the cellular level, so we started to accumulate amyloid plaques to inhibit the transmission of information from neuron to neuron, and then this leads to tau the myofibrillar tangles to inhibit all functions of the neurons. So this clog actually builds up around the neurons, and then the inhibits the regular function of neurons. So very small area that we look at it in the between the nerves, actually when the amyloid is being released to the extracellularly, so in between the neurons. So initially actually it was not really many, but if we produce many more, this becomes actually much more toxic. And I actually make an analogy for amyloid. Amyloid is it is like a tapioca. So if you make more, it sticks everywhere. So when you make it more and more, it becomes much more toxic. It becomes oligomer, which very few of them. Once you are making more, it becomes much more. It's called protofibril. And then once these are bigger, it becomes like a tangle. And then when it's tangled, so it inhibits the other neurons to communicate with this neuron. So microscopically, grossly, this is normal brain, normal hippocampus. I wanted to share this as how real life looks. So you would see these the little gyri, like indentations, become much more prominent. As well as when you look at it inside the brain, you can see clearly shrinkages. And then most prominent in Alzheimer's disease in these two regions that you are seeing, hippocampus as well as the temporal lobe, this area become much more shrunk compared to the rest of it. So what are the risk factors for Alzheimer's disease? So biggest risk factor that we know is the age. So a person when become much older, this risk actually increase. When 65 years old, the risk is 10%. But when you become 85 years old, it becomes actually 40%. So the second thing that I wanted to mention in genetics, the family history is very important. I get to be asked a lot of questions if the family history is important. Yes, there is definitely an importance. And then the other thing that I wanted to mention is ApoE4 genotype. So this is actually is not a cause for the Alzheimer's disease, but having this allele increases the risk, which I'm going to explain to you in detail in few slides. So gender, there is like there seems like more female to male, and then so the other risk factors, if the cognitive reserve actually is important. If the person has a higher cognitive reserve, we see less risk with Alzheimer's disease. So these actually cognitive reserve is defined by social isolation. So the person is much more social, is less likely to get Alzheimer's disease. So if the education, the years of education, or like how many years of undocumented education even counts, actually reduces the risks for Alzheimer's disease. And then the how complex the job that we do day to day actually have an effect on the risk as well. So the last one is I wanted to mention is vascular risk factor. So if you keep your heart and your vessels happy, so brain is going to be happy, and that reduces the risk of Alzheimer's disease or any type of other dementias. So the APOE gene that I was mentioning you, so this actually, let's give you a brief information about the genetics, how genetics works. So we have always had 2 copies for each gene. One comes from the dad, one comes from the mother. So this gene has 3 different combinations that this gene can have. So those are, we call it with the numbers 2, 3, and 4. I'm not sure, like we don't really have the 1, but like, focus on as 2, 3, and 4. So based on these, the possibilities, the one or progeny or the kid would have 6 different combinations. So as I was mentioning to you, if the person gets ApoE4 from mother or father or both, increases the risk for Alzheimer's disease. So that doesn't mean that if the person has ApoE4 is going to get Alzheimer's disease. There are people in our cohort, and we know that from the literature, who has no E4 become Alzheimer's disease, and there are people who actually has ApoE4 who never develop Alzheimer's disease. Those people, we don't know how that happens, but there is a possibility that this gene doesn't really lead to an Alzheimer's disease, but increase the risk factor. So in the normal population, so this ApoE4 only composed of 25% in general, okay? And then the most of it is actually 64% people have ApoE33 or other combinations, like the 2-3 and 2-2. So when we look at the Alzheimer population, though, we see 2/3 of the Alzheimer patients have ApoE2 carriers. Whereas I was telling you, it's only 1/4 of the ApoE carriers that we see in the normal population. And 15% of these Alzheimer population has ApoE4 2 alleles of this gene. So why is this important? So the ApoE4 actually shifts the Alzheimer's disease presentation, the presentation age to younger ages, and increase the development of Alzheimer's disease. So as you can see, so in this graph, ApoE44, 50% of the people with ApoE44 has Alzheimer's disease by the age of 70. Whereas if you look at it 3-3, 50% of them actually develops Alzheimer's disease around 82 years of age. And 2-2 is the very good allele, but it also causes other diseases itself. So we don't really see much of a 2-2 in Alzheimer's disease population. So how do we treat Alzheimer's disease? So as if you had already experience coming in here, or if you have loved one already coming into our clinic, you may these medications already. So this the cholinesterase inhibitors as well as the Namenda has been on the market for many decades. So we have been using these before actually these new drugs came in. So what these do actually increases, so the cholinesterase inhibitors actually increases the acetylcholine levels in the brain, which helps the memory formation and then keeping the memory, keeping the attention intact in long run. And then the Namenda also protects the nerves, so we have been using these drugs. But these two drugs doesn't really affect the progression of the Alzheimer's disease. It helps to reduce in long run the nursing home admissions that we know of based on our research. So, and then this new two drugs actually is called a disease modifying drug. What it does actually, it delays the progression of the disease. So it has an effect in the disease progression. So these are the two that is of now approved for FDA. How do they work? So I'm going to talk about the Lequembi first, and the other medication, donanemab, also affect the same way. So what it does, these are actually antibodies that are raised against the amyloid molecule. So when it is given to the body, it recognizes the amyloid in the brain, and it just pulls out from the brain and gets rid of the plaques from the brain. So effectively, it reduces or it eliminates amyloid plaques from the brain. So as you can see, the if you remember this picture from the beginning, so it affects over here and over here. So these are our little drug binds over here and then pulls it to pulls it and clears out from the brain. So this is fully approved in July 5th, 2023, and we started using in December 2023. So our first patient actually received the infusion in January 2024. So what it does, this actually completely removes the plaques. And then it doesn't really, as I mentioned, it doesn't really stop the disease progression, but slows down the progression of the disease, which I will explain why this is happening. So at the end of it, it is not a cure, but it actually delays the progression. So if you look at it over here, this is a brain images, brain pictures with the specific dye used as amyloid PET scan. So this person is, initially actually was like this. All these red stuff is the amyloid plaques. When we give the drug, if in the 18 months, after 18 months, the checkup, we don't really see any plaques actually afterwards. But if there is no drug, as you can see, it progresses to more plaques. So the clinical trial shows us actually, so this plaques is being reduced to the almost undetectable levels with the lecanemab, as well as the donanemab, the other medication that I'm going to discuss. So when we look at this into the memory and the daily functioning, so what it does actually, so this green line shows the progression of Alzheimer's disease with the drug, and the black line shows the placebo, which no drug. So you can see after 6 months there is the improvement that we can detect after 6 months. So with long run, so we do see at least 27% slowing by Lequembi by 18 months. So looking at actually this graph differently by instead of horizontally, looking at the horizontally, what we found, if we treat the person with 4 years with this treatment, the person would gain 1 extra year, the extra year for the cognition. And then functional decline in activity of daily livings is slowed down by 50%, allowing a gain of 1.6 years. So benefit is greater in the early stages of Alzheimer's disease. So this 27% actually comes up to 35% slowing, so compared to advanced mild Alzheimer's disease. So bottom line, starts as early as possible to maximize the benefit. So anti-amyloid treatment side effects, what are they? So most common side effects are the infusion-related and the reactions. So think about it like, when you get vaccination. So it is expected to have like cold-like symptoms. This is exactly how it is with the medication that someone is getting the Lequembi or the donanemab. So we call this infusion-related reactions. So I define what those are: fever, flu-like symptoms, nausea, vomiting, dizziness or lightheadedness, shivering, change in heart rate, feeling like chest is pounding, difficulty breathing, or shortness of breath. So this is probably the extreme, but so these are infusion-related reactions. So other most common side effect is swelling in the areas of the brain with or without small spots of bleeding in or on the surface of the brain. So we call this ARIA, which I'm going to show you. And then another most common side effect is the headache, which goes away. So what is ARIA? Amyloid-related image abnormalities. So these actually is found in the MRI. Most of the time, actually, we don't really see, we don't really hear symptoms that is being presented when someone has this. So this happens very silently most of the time, but in the MRI images, there are severe stuff that can happen, or sometimes mild can happen. So as you can see, this is an edema. This is coming from actually European resources. That's why it starts with O in this picture. So this is actually the edema in the brain. So this is a brain picture, and then this is like effusion that you can see, little white spots that on the images. So you don't really experience much. Maybe this one will cause you some visual problems, but most of the time like this. We don't really hear any problems from the patients. So, and then in terms of the bleeding, so I'm not sure you're able to see these little dots. So it can happen. So this is the normal brain, how it looks like. So if the microhemorrhages, it's microhemorrhages means a small bleedings in the brain, can happen like this, small spots. And then over here, there's small spots on the surface of the brain. So even though, as I was telling you, I will show you a graph next, actually, to show how much these actually happens and how much of them is actually symptomatic. But most of the time, it's not symptomatic. So someone won't experience anything. If there's an experience, that would be headache, confusion that gets worse, dizziness, vision problems, nausea, difficulty walking, seizure. I usually say that it simulates like a stroke symptoms, sudden start, and then most of the time one-sided, because that doesn't really happen symmetrically. So this is a little bit more information, a little bit more examples again. So some edema that you can see, anything that is white, it represents the water. So like, the seeing these little the white spots is edema, and then these are the little spots of bleedings that you can see. So earlier risk increases with APOE4 genotype, as I was mentioning to you. So in the area edema risk actually increases about 1 in 3 people with the 2 copies of APOE. So when you have 1 copy, it's pretty much like, the much lower, less than 1 in 10, so around 1 in 10 in 1 copy, and then 1 in 20 if you don't have any copy. So obviously this drug increases the risk, but the APOE genotype, E4 genotype increases much more significantly. So H, which is the microbleed, so small bleeds, also increases with the age. However, it increases with the APOE genotype. However, we know that even the placebo will have some of the bleedings without having medication. So, and then these have actually detailed information if you want to go through. And now when you look at the symptomatic area E, So there's very few people actually experience those symptoms that I told you. 1 in 10, the 1 in 50, 1 in 60 actually experience some symptoms. If you have one APOE4, 1 in 10 can experience the edema symptoms. And now symptomatic ARIA-H, regardless of APOE, is very rare, as 1 in 150 almost. And then if there is the placebo, we can only see 1 in 500. So how do we monitor this? So since there is not really much of a symptoms, we have to have an established monitoring of this. So this is our infusions. So this drug is given as an IV infusions every 2 weekly for 18 months at the infusion center. And then it is given every 2 weeks. And then we do, before we start, we do an MRI, the baseline information to decide who is going to get. In the same time, we also do an APOE4 allele, which Kim is going to go through in detail about this. But we monitor 3 very crucial MRIs on the 2nd month, 3rd month, and then before this the 6-month infusions. The reason is we do this, it's the most pronounced, like, you know, the ARIA-E and ARIA-H happens within this 2 to 6 months period. So I'm going to stop right here. And so one more slide. So this is our other drug that is also being approved in 2024. We are in the process of getting this medication. So I just wanted to mention that we are not really currently have this medication, but our pharmacy is working hard on getting this. Probably in few weeks to month, we will probably offer this as well. So this actually has a similar effect with Lequembi, and it has it has between 35 to 22% improvement in the memory. However, this is much more aggressive medication, and it can cause more ARIA-E and ARIA-H depending on APOE genotype. So again, this also slows down the disease, but it is not a cure. So the last question is, why doesn't it stop AD completely if it removes plaque completely? So the reason is that once AD pathology starts, other catastrophic events actually happens in the brain that are not really associated with amyloid plaque. This drug only targets amyloid pathway, not the other ones. So these are the other diseases, other pathologies that we see up to like 42% has other pathologies that this drug doesn't really have an effect. So expectation is not a slowdown. So I wanted to ask if there's any questions in the chat, or if there's anyone wanted to.
There's no questions in the chat yet, so if you can either type them in the chat or you can take yourself off mute and ask the question.
Thank you.
Thank you, Dr. Coskun. And now we're going to bring up Kim Lowry. She's our nurse practitioner here at Sanders Brown, has been here since 2019 working at the clinic and works with the Lequembi clinic every week as well. Kim, welcome.
So I might talk about, before she starts actually, I might talk about it. This question I always get is, what is the healthy brain? So what can we do to reduce the risk of Alzheimer's disease? So especially if someone actually is diagnosed, if they know that APOE4 genotype, as I said, that risk is high, so someone can just make preventive measures like exercise, as everyone says, exercise, eat a hearty, healthy diet, and reduce stress. Of course, quit smoking, and I should include that it's quit also alcohol as well. So, or moderate alcohol would be okay. 1 glass is recommended. Engage in social and mental stimulation activities. So these are keeping your brain healthy. I usually recommend starting something that you never done it before, and then try to learn the new language. Try to learn how to sing or play an instrument would be the greatest advantage, the greatest benefit for your brain. So I guess we don't have any questions.
No, so far.
So far. Okay.
Good morning. I'm Kim Lowry, the nurse practitioner here at Sanders Brown. I also help run the Lequembi clinic. So I'm going to pick up sort of where Dr. Coskun left off. This is what's going to happen when you actually come to Lequembi clinic. So Dr. Coskun already talked about the medication and what it does, and so this is kind of picking up from there. So initially you're going to come into the Lequembi clinic. So how do you get to the Lequembi clinic? So if you're on our research side, you might be referred by a clinical coordinator, or if I was to see you on the research side, or one of our other providers, we might suggest you come to the Lequembi clinic. If you're also a patient on the memory care center side, we might suggest Lequembi for you. So when you come to Lequembi clinic, we discuss Lequembi and what the medication does. So sort of the information that Dr. Coskun had already presented to you all earlier. So we'll go in depth of what it does, the criteria that you need to meet to do Lequembi. We talk about the possible side effects. And so then there's a workup that needs to be done for you to qualify for Lequembi. And that starts out with cognitive testing. That can be a MOCA, a Kochman, or an MMSE. You have to be within a cognitive test scoring range to qualify for Lequembi. Right now it is only approved by the FDA for people with mild cognitive impairment or mild Alzheimer's disease. We'll also need to get a recent MRI. That would be within a year for part of the workup. Genetic testing, as Dr. Coskun had talked about before, we need to know your APOE status. She went over the kind of combinations of the different combinations you could have. I'll go into a minute why that's important for us to know. We'll also need to get a lumbar puncture or a PET scan, amyloid PET scan. Now, we get the same information from those two procedures, and it's just kind of personal preference as far as which one we choose. We also look at other things like if you've had a lot of back surgeries or back injuries, that might be hard for them to do a lumbar puncture. And so there's other things that kind of play into that, which one we decide for you to do. We have a nurse navigator that works with us to help schedule the additional workup that you might need. So going back to the very first thing that you need to do is the cognitive test. That is something that we do in the consult with you. Those are takes about 10 or 15 minutes, and like I said, it's a MOCA. The short-term mental status is a Kochman or an MMSE. Sometimes you may come in if we've recently seen you and you've already had one of those done. I will tell you the cognitive test needs to be within 3 months of us doing that initial consult and sending that information into your insurance company. So we may have to repeat that. Additional testing that we might need to do are the FAQ and a CDR. Those are also just a questionnaire that we do with you all. Typically with the initial consult and this initial sending in to get approval, we'll need at least an FAQ. Sometimes, depending on your insurance company, they may require us to do a CDR as well. So we'll go over your health history in detail. We want to know what medications you're on, especially anticoagulants. So this is things like Eliquis and Coumadin. They can increase your risk of having ARIA, and so we want to know if you're on those medications. We also want to know what medical devices you have. So if you can't get an MRI, then you're not eligible for Lequembi. So sometimes we have things in our body that prevent us from getting an MRI. So why do I need an MRI to start off with? So this is your baseline. This is for us to see what's going on in your brain. So we want to look for that you don't already have microhemorrhages. I believe Dr. Coskun spoke on CAA earlier, so those are lots of microhemorrhages. So if you have something like that, you would be ineligible for Lequembi. We also want to know, excuse me, if you're having the lumbar puncture, as I had spoken about earlier, then your MRI will need to be within the last 6 months before you get your LP. We also want to know where you got your last MRI. We might be able to use that information, but I will tell you that not all MRIs are created equal. So there are different sequences that might be ordered. And so if we don't have the sequences that we need to look at to approve you for Lequembi, even though you've had a recent MRI done, say, outside of the UK, we may have to get you to repeat that. Also, if you're on the research side and have done an MRI, doesn't necessarily mean that we'll be able to use that information on the clinic side. So even though you've had a recent research MRI, we may have to repeat that. So what's the difference between a PET scan and lumbar puncture? So as I said before, they're both looking at and giving us the same information. So how much amyloid is in, that you have. PET scans tend to be quite a bit more expensive than a lumbar puncture. However, it's not invasive. So it's like an MRI, you're just going to lay there for a shorter period of time. Lumbar puncture, you do have a needle inserted in your back, and your CSF fluid is removed. The most uncomfortable part about a lumbar puncture, it sounds very scary, but is the initial numbing of the area, which feels like a bee sting, may take about 10 seconds, but then that's going to go away. And when they actually insert the needle in your back, you're just going to feel some pressure, but there's no pain. Typically, with a PET scan, you're not going to have any side effects. With a lumbar puncture, you can have a post-lumbar puncture headache. We can treat those with medications. Also, if you're doing a lumbar puncture, when we do that initial workup, we're just going to have to add a few more labs, which are blood draw, to your workup to make sure that you can do a lumbar puncture okay. So this is the genetic testing that Dr. Coskun kind of touched on before. And so the reason why we want to do genetic testing with Lequembi is certain gene sequences can tell us that you're at increased risk for developing the ARIA, the microhemorrhages, or the edema. And it was found in clinical trials that if you have an E4-E4 combination, that significantly increases your risk of developing ARIA. So we also want to have that piece of information so when we start going over all your workup, we can tell you if you're at that increased risk. So when you come in for that initial consult and you decide you want to continue with Lequembi, we'll order all those labs that I just talked about. Once those are all done, we will bring you back in to discuss all the results at one time. So that would be possibly your MRI, your amyloid PET scan, or your lumbar puncture, and your genetic testing. And at that time, we will tell you if you still qualify for Lequembi based on all that information, and if you want to continue after discussing the medication and how it works. Consent forms will be signed, and then that is sent over to the neurology specialty pharmacy. So what is covered? So Medicare right now is paying about 80%. And your cost would be 20. We have most insurances that we see are following that same suit. Also, if you have any supplemental insurance, that may kick in as well. For additional help, Eastside, the makers of Lequembi, and UK Pharmacy also have programs that can help assist you. And if that's something that you're interested in, our nurse navigator can work on that with you. So once the pharmacy gets the approval, they're going to reach out to you and do another consult. This will be a telehealth visit. They'll go in depth over the medication once again and talk to you about the side effects and everything. And so if you have any additional questions at that time, you can cover it. Then it will go on to your insurance company, come back to the specialty pharmacy, and then they'll send it on to the infusion center to have them call and schedule your first infusion. So our infusions are done at Gill Hart, which is at the hospital, and then we have an infusion center on Wellington Way, which is over there behind the mall Target area. I don't think it's changed, but what type of insurance you have determines which one of these infusion centers you go to. I know they are working on that to where you can choose. I don't think it's gone through yet. Have you heard
about
the infusion centers and you been able to pick yet? I know at one time.
So it is, I think, set with the Medicare, Medicaid is the
Still with the insurance company? Okay.
Medicare, Medicaid goes to Wellington.
Okay. Infusions are every 2 weeks for 18 months. During that time, we're going to do 3 safety visits. They all occur within the first 6 months. Safety visits are kind of scheduled when during clinical trials they discovered that ARIA was most likely to develop. And so you're going to have a safety visit after your 4th infusion, and then after your 6th infusion and your 13th infusion. The safety visit will consist of, that might be on my next slide, no. So the safety visit, our nurse navigator will have, get an MRI scheduled, and so you will have to do another MRI. You'll come into the clinic on a Friday and we'll review your MRI, do a short neuro exam and see if you're having any signs or symptoms. If your MRI is clear and you're not having any symptoms, then we will send this back to the pharmacy, telling them that you're clear to go on to your next infusion, and they'll reach out to the infusion center and you'll start the process over as far as getting the infusions. And then, for example, if this is your 4th infusion, you'll come in, you'll have your MRI, you'll see me or one of the other providers, and then we'll send you out, and for that one it's a short period, we'll see you back in 4 weeks to do another safety visit. After your 13th infusion, that will be your last safety visit, and you won't have to get any other MRIs until the very end. So we still want to see you every 6 months. Lequembi is kind of separate from your every 6 month follow-up. And so typically with that 13th infusion, because that's at a 6 month mark, we'll schedule a 6 month follow-up back to your normal every 6 month follow-up, if that makes sense. So I know Dr. Coskun has kind of already touched on this, but these are some infusion reactions and what you can expect or look for. Also with if you develop ARIA. Now, I think it's about 90% of the time ARIA is asymptomatic, so you may not get all the more severe reactions, but just so that you know in case you do develop them. So headache, confusion, dizziness, vision changes, nausea, difficulty walking, seizure. So depending on how bad these are, like the headache and the nausea, we can pre-treat those before you have your infusions if we see that you're having those. Obviously, if you're having the more severe reaction, we would want you to call us immediately. If you happen to go to the emergency room, it's very important to tell them that you're on Lequembi if you go there for any reason. I kind of gone over this. So at the safety visit, this is when you'll have the MRI. We will compare that to your baseline MRI. So that's why it's important we get that initial MRI so we can have this to compare to. This is not something that you have to schedule. Our nurse navigator will schedule the MRIs and the safety visits, and she will keep up with what infusion number you're on for you. So what happens if you come in and we look at your MRI and we see ARIA? So depending on how bad it is, we have some options. So typically we're going to pause your infusion for a short period of time. This could be a month. And then we're going to repeat the MRI to make sure that, for example, if you're having edema, that this has resolved. We may need to pause it for another month. Depending if it's severe enough, we may have to stop your infusions completely. And then at this time, if you have any questions about my presentation or Dr. Koskun's presentation, we can answer those questions for you all.
One question is, how do you get the whole process started? How do you get a referral to Lequembi Clinic?
So, as I had said, if you're on the research side, that may come within UK itself. Or if you're on our clinic side already and we see you, we might tell you about Lequembi, ask you if you're interested, and go from there. You can have referrals from outside facilities. Are we going to go ahead?
So if you're concerned about your memory and you think that you have Alzheimer's disease and you don't really come to our clinic, I think it's best to go to your primary care and request referral to us, and then just mention them that you wanted to have the referral for Lequembi Clinic, so that we have a priority for this the clinic if you have the Alzheimer's disease, mild Alzheimer's disease or MCI, because as I was mentioning earlier in my talk, the earlier diagnosis actually increases the chances of this medication's the benefit. So if you don't come to us, if you are seeing outside the primary care, so you can ask them to refer to us as a Lequembi referral. Okay, so use this word Lequembi or anti-amyloid treatment referral. Okay. That. Any other questions? No?
Okay. I don't know if anybody gave, so Lequembi also has a website, so if you want to just kind of get some information about Lequembi, it's is it on?
No, I'm just gonna write it on.
Oh, yeah. Lequembi.com, and so they have talk about the medication, how it works again, so the part that Dr. Coskun talked about, and then it'll go into what I've discussed as far as the workup, the APOE testing, and what you'll need, and then it also talks about the number of infusions and how often you'll have to do that safety visit. So it kind of goes over all this. Again, if you want to reach out and look at that website, that'd be a great place to get some information. And then you can come in and have questions written down that we could go over.
So this is the site. You can go through details, and then there are videos on this page that you can watch to get more information.
So I want to thank you both for coming and sharing about this information. I know there's lots of questions. We will work on getting this video recorded and put up online. And for anybody who registered, I'll send out the link once it's up and posted so they can view it again and get to see any more. And sometimes it takes a few times to get all the information to click. So this is a lot. So thank you very much for taking your time to share with us.
I think we will do this periodically, right?
I think so.
So if you like.
Thank you.
Thank you.
Very much.